now we are going to discuss the next system in trauma, neurosurgery. Okay, we are going to go to the next system on neurosurgery. So neurosurgery, trauma part we are going to discuss now. So this comes as AIS-1 head injury. Okay, this comes under AIS-1 head injury. So in head injury, I have to discuss some basics from physiology. Let me discuss some basics from physiology. So normal cerebral blood flow, how much is it? Normal cerebral blood flow is 55 ml per minute. Please remember, it is 55 ml per minute is the normal cerebral blood flow. Ischemia happens when the blood flow is less than 20 ml per minute. Ischemia will happen in brain. How to prevent this ischemia is by maintaining cerebral perfusion pressure at a value of 75 to 105 millimeters mercury is a normal cerebral perfusion pressure. So the cerebral blood flow of 55 ml per minute, how can you maintain this? The cerebral blood flow of 55 ml per minute can be maintained when the CPP, cerebral perfusion pressure, is 75 to 105 millimeters mercury. It is nothing but mean atrial pressure minus intracranial pressure. The value of CPP is mean atrial pressure. What is the mean atrial pressure? 90 to 110 minus intracranial pressure is 5 to 15. So this gives a value of cerebral perfusion pressure. So you must know this because for cerebral brain flow 55 ml per minute, the cerebral perfusion pressure should be 75 to 105 millimeters mercury. And here comes a very important doctrine from Bailey and Rao. This is skull. Okay, this is skull and this is midline and this is the brain. We have the brain inside the skull. So the brain, and this is the CSF. The one which I am now drawing is CSF. This is CSF and this is blood which is in the skull, blood in the skull. So now there is a doctrine I want you to know known as Monro-Kelly doctrine. This Monro-Kelly doctrine, what does it say? This says skull is a closed compartment. At any point of time inside your skull, the brain, CSF and blood is a constant. Brain, CSF and blood is a constant at any point of time. In your skull, brain, CSF and blood is a constant. If one increases, for example, if the blood component increases, it will compromise the other components like brain or CSF. So this doctrine is known as Monro-Kelly doctrine. So Monro-Kelly doctrine says in your skull you have three components. One is brain, another is CSF, another is blood. So if one component increases, it will compromise the other component or suppress the other component. This is known as Monro-Kelly doctrine. So please don't forget this Monro-Kelly doctrine. Okay. So because of this Monro-Kelly doctrine, now you should come to your idea what will happen. This is a skull. This is skull. This is a brain stem. This is brain stem. This is brain. This is brain stem. This is brain. And this is cerebellum. Now I'm going to tell you certain points, very important points. Please remember these points. As I told you, if the skull increases, the component in skull increases like this. Skull component increases like this. For example, if there is a hematoma here in the brain, there is a hematoma here in the brain. On this side, there is a huge hematoma in the brain like this. For example, assume this is huge hematoma in the brain. So as per Monro-Kelly doctrine, it should compress the brain. So the left side brain will be compressed and there will be number one, midline shift. That should be midline shift. Number one, what all will happen? So midline shift will happen, number one. And the cingulate gyrus can herniate. The cingulate gyrus will herniate. Cingulate gyrus herniation. And there will be herniation of the following also. What are the things which can herniate? Uncus of temporal lobe. Uncus of temporal lobe will herniate. Okay, uncus of temporal lobe will herniate. So I'm not drawing Paka brain. I'll show you the image from Bailey and Rao later. Uncus of temporal lobe will herniate. Please don't forget this. Uncus of temporal lobe will herniate. And cerebellum will herniate. Cerebellum will herniate. Brainstem will herniate. So all these are happening because of Monro-Kelly doctrine. There is a huge clot on one side of the skull and that clot is compressing the brain. Therefore, there is midline shift, cingulate gyrus herniation, brainstem herniation, cerebellum herniation, uncus of temporal lobe herniation. If the uncus of temporal lobe herniates, there will be pupillary abnormalities. Please remember, there will be pupillary abnormalities. Because of compression of uncus of temporal lobe, what will happen? The pupils will become unequal. And one such type of pupil abnormality due to oculomotor nerve compression is oculomotor nerve. For example, if I'm having a left side hematoma here, the oculomotor nerve is compressed here. What will happen to this eye? Ipsilaterally, what will happen to that eye? Ipsilateral, I will get fixed dilated pupil. Please don't forget this. Ipsilateral, fixed dilated pupil will happen on that side. If there is a hematoma here, that will compress oculomotor nerve, and that side pupil will be fixed and dilated. That side pupil will be fixed and dilated. Please don't forget. This pupillary abnormalities can happen in uncus of temporal lobe herniation. And what will happen in a cerebellum herniation? In a cerebellum herniation, you can develop Cushing's triad. Cushing's triad. Cushing's triad is made up of the following components: hypertension, bradycardia, and respiratory irregularities. Respiratory irregularities can happen. So hypertension, bradycardia, respiratory irregularities are the features of Cushing's triad. Please don't forget the features of Cushing's triad are these three: hypertension, bradycardia, respiratory irregularities. So now you can understand from Monro-Kelly doctrine what is happening because of pressure in the skull. The brain is herniating. So how can I prevent the brain herniation? That is the point, very important. The physiology is very important to understand traumatic neurosurgery. How to prevent the brain herniation is by, so there are three components: brain, CSF and blood. So there is blood component which is increasing. Therefore the brain is getting compressed. How to prevent this brain getting decreased is by decreasing the CSF. So one other method of preventing brain herniation as a primary trauma surgeon is you can reduce the CSF or reduce the intracranial pressure. You have to reduce the intracranial pressure. How to reduce the intracranial pressure is again an AIIMS question. Reduction of intracranial hypertension in a head injury patient. Number one, first you put the patient in head up position of 15 to 30 degrees. Raise the head up 15 to 30 degrees. Number two, we will give some injections. to reduce the intracranial hypertension, the things which we can inject are the following. Mannitol is a fluid of choice to reduce the intracranial pressure. It is an osmotic diuretic. It is an osmotic diuretic. Mannitol is the fluid of choice. Can we use diuretics? Yes, you can use diuretics also if BP is okay. If BP is fine, we can use diuretics also. But which is best? Mannitol is best. Mannitol injection is given. Number 3, the patient will be aggressive, irritated. So we should make them calm. We should make them calm. How will you sedate them? For sedation, we will give barbiturates. What you should not give? Barbiturates is given to sedate them. The thing that should not be given is diazepam should not be given. Diazepam, I am highlighting with the pink color what are the things that should not be done in trauma, head injury trauma. Diazepam will suppress the respiratory center, so you should not give diazepam, but we can give barbiturates. And we can give fixed prophylaxis. Fixed prophylaxis can be given. Fixed prophylaxis can be given with sodium valproate. We can give fixed prophylaxis for head injury patients. That is also accepted. And 5th, we can give to reduce the intracranial pressure. We are giving mannitol. And to sedate them, we give barbiturates. And to prevent fits, we give sodium valproate. And to prevent infection, if there is a open skull fracture, we should give antibiotics also, prophylactic antibiotics also. So naturally, you all will be stimulated to give one injection because it is having intracranial pressure. What injection that should not be given? That is steroids. Steroids are contraindicated. So to reduce the intracranial pressure, in a cancer in the brain, we can use steroids. But hemorrhage in the brain, we should not use steroids. It can stimulate multiple hormones. Already it is a stress. It will stimulate more stress hormones and you can get more problems. So steroids are contraindicated in head injury. And naturally, one person will think if you remove the CSF, the pressure will fall. So for that, we should not go and do a lumbar puncture. If you do a lumbar puncture, that's all you are gone. The patient will have brainstem herniation and he will die. So lumbar puncture is contraindicated. Steroid is contraindicated. Please don't forget the things that must not be used in trauma are steroids, lumbar puncture, and diazepam. The pink highlighted substances are not to be advised in the reduction of intracranial pressure. And what else I can do? I can give them external ventricular drainage. Sir, how to reduce the CSF then? By putting an external ventricular drainage. We can put an external ventricular drainage and reduce the CSF. We can reduce the CSF by putting an external ventricular drainage. And we can give nasal oxygen. You have to give nasal oxygen to prevent hypoxic brain damage. You should give nasal oxygen. And with all these things, what you must do in a trauma center is you must maintain certain neuro-intensive care unit values. In all these things, we have to maintain some neuro-ICU values from Bailey and Lowe. We have to maintain intracranial pressure at 20 millimeters mercury. You have to maintain a value of less than 20 millimeters mercury. Cerebral perfusion pressure should be 60 to 70 or more. The cerebral perfusion pressure should be 60 or more. And mean atrial pressure should be more than 90 millimeters mercury. So these are the neuro-intensive care values. To maintain adequate blood supply to the brain, what are things you should do? Maintain intracranial pressure less than 20, cerebral perfusion pressure 60 to 70, mean atrial pressure more than 90. Along with this, we also should maintain partial pressure of oxygen and partial pressure of carbon dioxide at certain values known as partial pressure of oxygen should be maintained at CO2 should be maintained at 35 to 45 millimeters mercury, and for oxygen should be maintained at 80 to 100 millimeters mercury. But the point is, this is not given in millimeters mercury in Bailey and Lowe. Bailey says this is as value of Pascal units. So oxygen is maintained at a Pascal unit of 10 to 12 kilopascal units. And this is at 4 to 6 kilopascal units. This is a rough value, but remember this. So what are the neuro-intensive care unit values you must maintain to have adequate brain perfusion and to prevent hypoxic encephalopathy? Please remember, intracranial pressure should be maintained at less than 20, cerebral perfusion more than 17, mean atrial pressure more than 90, partial pressure of oxygen at 10 to 12 kilopascal, and PaCO2 at 4 to 6 kilopascal, or otherwise 30 to 45 and 80 to 100. This is very important in trauma. Okay, so can you tell me which is the best method to reduce intracranial pressure? Best method to reduce intracranial pressure is by doing an external ventricular drainage. We take a scalp vein. That scalp vein will be put into the skull and that will drain the CSF out. That is the best method to reduce the intracranial pressure. Okay. Sometimes if the pressure is very high, we have to go for decompressive craniectomy also. You have to go for decompressive craniectomy also. So these are the basics in head injury. To understand the basics, you must understand the physiology and the basics. So your prime aim of you in a trauma patient is to reduce the intracranial brain pressure. Intracranial hypertension should be reduced. So any head injury patient, you should understand what is GCS. Glasgow Coma Scale. Without knowing Glasgow Coma Scale, you must not go to the exam. It is high yield MCQ and you should prepare it very smartly so that you won't forget it for your lifetime. Let me explain you simple method to remember for lifetime. So please don't forget the 3 points in GCS are eye opening, GCS, eye opening, verbal response and motor response. These are the 3 things I am going to see. Eye opening, verbal, motor. Eye opening I am going to give 4 points maximum, verbal 5 points, motor 6 points. So now eye opening, you are going to examine Ramu now. You are going to examine Ramu. You are going to see the following points. Ramu is spontaneously opening his eyes like this. You are calling him spontaneously opening his eyes. That is 4 points. You are calling Ramu, open your eyes. On call, he is opening his eyes as 3. On pain stimulus, you are pinching him, then only he is opening 2. Not at all opens is 1. That's all. Simple scoring system. Eye opening is very easy. Spontaneously opening. On call, he is opening. On pain, he is opening. Not at all opening. 4, 3, 2, 1. Certain times you should make mnemonics, and many times many students make mnemonic and they forget what is the expansion of each mnemonic word. I used to keep mnemonics only in such a way that mnemonics will not be forgotten and the mnemonics will help in understanding more easily. So verbal response, let me tell you one mnemonic. One confused word sounds nowhere. One confused word sounds nowhere is a mnemonic. One confused word sounds nowhere. So one confused word sounds nowhere is a mnemonic for verbal response. Very simple. See the mnemonic. One confused word sounds nowhere. One for oriented. The patient, Mr. Ramu is knowing where he is. He is oriented. Sir, I know where I am in this hospital. Like that is oriented. And I know where is my house, etc. 5 points. Ramu is confused. Sir, where am I? What happened to me? Like that he is confused. And he is using inappropriate words. Ramu is such a good fellow. He is using inappropriate bad words. He is scolding you. Inappropriate words due to brain irritation. Inappropriate words. Otherwise he is very teetotaler. He won't use any bad words. He is using all sort of bad words now because of irritation. Inappropriate sounds. No sounds. So this is 5, 4, 3, 2, 1. Verbal. One confused word sounds nowhere. Simple mnemonic. And similarly coming to motor response, I will take a simple, more easy simple mnemonic. Obey. Localize. Obey, localize. Local people with fluxion, extension now. Obey, localize with fluxion, extension now is a mnemonic. Very simple, you can see. Now I can make motor response very. Obeys command. I'm asking him. Touch the nose. He obeys command. That is 6 points. You're asking where is the pain? He's telling sir, my pain is in the right eye, left eye, right eye. That is localizing the pain. That is 5 points. When you touch him, he is withdrawing. That is 4 points. Withdrawal is 4 points. He is lying in a fluxion deformity like this. He is lying in a fluxion deformity like this. That is known as what rigidity? Fluxion deformity is known as decorticate rigidity. That is given 3 points. Extension rigidity is lying like this. He is lying like this. Decerebrate rigidity. That is 2 points. No response at all. He's not at all moving. That is on painful stimuli also he's not moving. That is 2 points. 1 point. So please remember what are the mnemonics. Obey, localize with fluxion, extension now. Obey, localize with fluxion, extension now. 6 points over. One confused word sounds nowhere. 5 points over. Okay, no need of mnemonic for eye opening. So with this I'm going to tell 7 MCQs now from GCS. 7 MCQs I'm going to tell from this scoring. So please remember which is the best of the 3 to assess GCS. Best of above 3 in assessing the GCS. Best of above 3 is motor response. Okay, motor response is the best to assess the GCS. And what is the maximum score and what is the minimum score? Maximum score is 15, minimum score is 3. For a dead fellow also the score is 3. Okay, when you intubate a patient, intubation is done, orotracheal, nasotracheal or tracheostomy intubation is done, we cannot test the verbal, you cannot ask the patient who is intubated, what is your name like that, they cannot tell. So for a patient who is intubated, we give it therefore a score VNT known as B, not testable, 0 point. Verbal not testable, 0 point, no point for that. Okay, verbal not testable. When will you intubate? Already I told you this answer. In a head injury, when your GCS is less than or equal to 8, you must intubate. When the GCS less than or equal to 8, you must intubate. At admission, when will you take CT scan? When the GCS less than or equal to 13 at admission. I'm going to tell you 7 MCQs, please don't forget. Best of above 3 is motor, maximum is 15, minimum is 3, intubation is at V and T is 0, intubation should be done at less than or equal to 8 and GCS less than or equal to 13 at admission. And last point is, in motor, let me show you 2 responses. With this hand I can localize the pain. So localize, but this hand is an extension like this. Extension, localizing the pain. Which score will you take? For example, my left limb score is 5. Right limb score is, in extension rigidity, what is it? Extension rigidity is 2. Left limb score is 5. Right limb is 2. Which score will I take? I should take the best score. Best score is taken. If there are 2 different scores in 2 different limbs, take the best score. So I will take the best score of 5 better than 2. So when I'm doing a counting, I will take 5 as the score. If there are 2 different scores in 2 different limbs, I will take the best score. Okay, I will take the best score. So these are the points in GCS. And in GCS, with GCS, there is a classification of head injury known as minor head injury. Minor head injury, mild head injury, moderate head injury, severe head injury is the classification. Minor, mild, moderate, severe. So minor is a score where the GCS is 15, normal, and there is no LOC at all. No LOC at all. Just he is having a head injury, no LOC, GCS is 15. GCS 14 or 15, okay, with LOC plus is mild. 14 or 15 with LOC plus is mild. 9 to 13 is moderate, and less than or equal to 8 is severe. Now you can understand why I told you intubation. Intubation is done for severe head injuries cases. So the head injury can be classified into minor, mild, moderate, severe. Minor means normal score. Mild means 14 or 15. Severe means less than or equal to 18. So you can easily remember, moderate is the one who is having score between 9 to 13. 9 to 13. Okay, so these are the classification of head injuries. Please don't forget these points in head injury GCS classification. Now what I should do? I should look for some clinical features of head injury. Some clinical features, let me tell you, you should tell where all that happens. So I'm going to tell certain clinical features. And let me tell first, Hutchinson pupil. You are examining the person, is having Hutchinson pupil. What is it? Hutchinson pupil is fixed dilated pupil. Where I told it? Fixed dilated pupil in oculomotor nerve stretching. Oculomotor stretching. So this is one sign of head injury. Signs of head injury are Hutchinson pupil number 1. I'll show you the images. Hutchinson pupil number 1. Fixed dilated pupil. This is helping us. For example, if your patient is coming to you with a fixed dilated pupil on one side, for example, this is a patient, he's having a huge hematoma this side pupil is dilated. Without taking a CT scan, if you are asked to put a burr roll, without taking a CT scan, it's very emergency, put a burr roll immediately, sir. There is an immediate need of burr roll. That time we will put a burr roll on the side of fixed dilated pupil. On the side of fixed dilated pupil, you should put a burr roll. You should put a burr roll. So this one point you should not forget. And usually the patients will have, if there is a hematoma on left side, patient will have left side hemiplegia. Contralateral hemiplegia will be there. So contralateral hemiplegia. If there is a hematoma left side, there is right side hemiplegia. This is normal. But there is one interesting phenomenon known as Kernohan-Notch phenomenon. Kernohan-Notch phenomenon. Kernohan-Notch phenomenon. What is it? This is an interesting phenomenon. There is a huge, see the image, there is a huge hematoma. Because of huge hematoma, this brain will shift to opposite side and it will go and compress the opposite side pyramidal tract, and it will cause ipsilateral hemiplegia. This is known as Kernohan-Notch phenomenon. Kernohan-Notch phenomenon is, I am having hematoma here, I should have hemiplegia right side. But in this patient, the hematoma is very high, that it is compressing the opposite side pyramidal tract and I am having hemiplegia this side itself. This is known as Kernohan-Notch phenomenon. So you should observe for hemiplegia. You should observe for hemiplegia, next point. And you should look for CS of rhinorrhea. CS of rhinorrhea. Raccoon eyes. Raccoon eyes is a black eyes due to subgaleal or subgaleal hematoma. Black eyes, also known as raccoon eyes, also known as panda eyes. Panda eyes. Panda eyes, raccoon eyes, CS of rhinorrhea. All these are features of base of skull, anterior cranial fossa fracture. Anterior cranial fossa fracture. These are the fractures. Anterior cranial fossa fracture causes all these signs. Okay, all these signs. Middle cranial fossa fracture causes one sign known as battle sign. Middle cranial fossa causes pigmentation on the mastoid process. Over here you get battle sign. Pigmentation or bruising over the mastoid process. Bruising over the mastoid process is known as battle sign. CS of otorrhea will happen. CS of otorrhea will happen. That is battle sign. So battle sign is bruising behind the ear. CS of otorrhea. All these features of middle cranial fossa fracture. Middle cranial fossa fracture. There is a controversy. Many books will say battle sign is for posterior cranial fossa fracture, but correct answer from cranial fossa fracture. Anterior cranial fossa fracture is recognized. Battle sign is middle cranial fossa fractures. Please don't forget these points in base of skull fractures. So base of skull fracture, CS of rhinorrhea, and recognized anterior cranial fossa fracture. These cases, the following are contraindicated. Nasogastric tube should not be put. Nasotracheal intubation should not be done. Okay, so nasotracheal intubation should not be done. Nasogastric tube should not be done for anterior cranial fossa fracture. And if there is a CS of coming out in an anterior cranial fossa fracture, you can put it on a tissue paper. You can put it on a tissue paper that fluid which is coming from the nose. You put it on a tissue paper. That blood will be seen in the center, and the CSF will be seen coming around the blood like this. And when you test the CSF, that will be having beta 2 transferrin elevated. That will be having beta 2 transferrin will be elevated. So these are the points of anterior cranial fossa fracture. How to say this is a anterior cranial fossa fracture is we have to see for epistaxis, CS of rhinorrhea, anosmia, and cribriform flake fracture. You should not put a LCU. Raccoonized, spondyles, all these are features of anterior cranial fossa fracture. Please don't forget how to say this is CS of rhinorrhea is by putting on a blotting paper. You can see the central blood surrounded by CSF. Like a ring. This is known as anterior cranial fossa fracture. So please don't forget these points between anterior, middle, and what about posterior cranial fossa fracture? Yes, there is one more fracture known as posterior cranial fossa fracture. In posterior cranial fossa fracture, the major disturbance we get is visual disturbance. The major disturbance is visual disturbances we get in posterior cranial fossa fracture, and we get a syndrome of paralysis of cranial nerves from 9 to 11 known as Bernard syndrome. Cranial nerve paralysis of 9 to 11 known as Bernard syndrome, which is also known as jugular foramen syndrome. So what are the features of posterior cranial fossa fracture means? Please remember, Bernard syndrome is a fracture 9 to 11th nerve paralysis due to jugular foramen compression known as Bernard syndrome. So these are the clinical features of your head injury patient coming to your hospital. So please don't forget Hutchinson pupil is fixed dilated pupil, and CS of rhinorrhea in anterior cranial fossa, CS of otorrhea in middle cranial fossa, posterior cranial fossa we get Bernard syndrome. All these are various clinical features. So as a general surgeon or as a trauma surgeon, you should know all these points. And at this time, you will advise them to take a NCCT. What is NCCT? Brain. You will advise them to take a non-contrast CT of brain. And what is the NICE guidelines? NICE guidelines is that for non-contrast CT of brain. So what is the indication of taking CT in 1 hour? Within 1 hour of trauma, when will you take CT scan? When the GCS is less than or equal to 13. When the GCS is less than or equal to 13. When the GCS is less than or equal to 15 at any time, at any point of time. Okay, so at any point of time, after 2 hours. After 2 hours, the patient has GCS less than or equal to 15. After 2 hours, immediately you should take CT scan. So please understand, when will you take CT scan? GCS less than or equal to 13 at admission time. Patient is getting admitted in your ward. He is having GCS less than or equal to 13 at the time of admission. After admission, he is roaming in the ward. He is there in your ward for more than 1 day. Suddenly, at any time, his GCS becomes less than 15, not less than or equal to 15, less than 15. At any point after 2 hours of admission in the hospital. Then also you should take CT scan within 1 hour time. And patient having focal neurological deficit. Please remember, patient having focal neurological deficit. Open or depressed skull fractures. Open or depressed skull fractures. That's a fracture. It is open fracture or depressed skull fracture. More than 1 episode of vomiting. Not 1 episode. More than 1 episode vomiting. A patient has seizures. So please remember, when will you take CT scan? Within 1 hour in a trauma patient, head injury patient, or GCS less than or equal to 13, less than 15, focal neurological deficit, open or depressed skull fracture, more than 1 episode vomiting and seizures. And what are the indications of taking CT in 8 hours? So not so emergency, but better take it in 8 hours. Better take it in 8 hours. Not an emergency, not to be taken within 1 hour, but better to take in 8 hours. Age of the patient is more than 65 years. Patient is on anticoagulant. Patient is taking some anticoagulants, and patient is having retrograde amnesia. Or retrograde amnesia for more than 30 minutes. Patient is having retrograde amnesia for more than 30 minutes. And history of dangerous mechanism. The patient is telling, sir, I'm walking on the road, suddenly a train came and hit me and I came here. Or I fell down from the 5th floor and I walked to hospital. Like that is telling a dangerous mechanism. So we are unable to even believe that mechanism. Such cases also you take a CT scan in 8 hours. These are the NICE guidelines. The NICE guidelines says in 1 hour when will you take CT scan, and when will you take CT scan in 8 hours. Patients on anticoagulants about 65 years, dangerous mechanism, retrograde amnesia. These patients we must take CT scan in 8 hours. Okay, these are the points you should not forget. In non-contrast CT, in non-contrast CT, I can get 3 images in a head injury. 1, 2, 3. These are the 3 skull. In image number 1, I will get a hematoma like this. What is this hematoma? It is EDH, extradural hemorrhage. In image number 2, I am getting a hemorrhage like this. This is SDH, subdural hematoma or subdural hemorrhage. And in image number 3, I am getting hemorrhage inside the brain like this. It is intracerebral hemorrhage, which also includes subarachnoid hemorrhage. So there are 3 hemorrhages in trauma: EDH, SDH, ICH. So in trauma, EDH, SDH, and intracranial hemorrhage are the 3 types of hemorrhages we get. So EDH is giving an appearance biconvex appearance. SDH is giving an appearance concavo-convex appearance. Okay, so subarachnoid hemorrhage or intracerebral hemorrhage is the third one, which is the most common type of hemorrhage in the brain. Most common type of hemorrhage in the brain is intracerebral hemorrhage, in which putamen hemorrhage is most common, which happens in case of hypertension causing CVA is due to putamen hemorrhage. So the most common type of intracranial hemorrhage is intracerebral hemorrhage, putamen hemorrhage. Usually no surgery done for these cases. No surgery done for intracerebral hemorrhage. No surgery is done. Okay, please remember this point. So we will do intervention only for EDH and SDH. EDH is biconvex, SDH is concavo-convex. EDH patients will have lucid interval. They will have lucid interval. Please don't forget, they will have lucid interval. Lucid interval means what? What do you mean by lucid interval? A patient gets head injury, he's developing head injury, he himself walks to the hospital and he is doing all sort of activities and suddenly feeling unconscious. This is known as lucid interval. That is a period of normal consciousness before he goes for LOC. This is reason is there is a slow expanding hematoma. The hematoma is slowly expanding and it takes some time to cause LOC. So this is known as lucid interval. In subdural hemorrhage, there is no lucid interval seen. In subdural hemorrhage, there is no lucid interval seen. There is history of LOC from the time of trauma. From time of trauma, there is history of LOC. And what is the reason for EDH? EDH, what is the reason? SDH, what is the reason? EDH is an injury of Pterion bone, the thinnest bone in the skull is pterion. The pterion bone, the thinnest bone gets fractured, and because of that fracture, we have an injury of middle meningeal artery bleeding happens. Middle meningeal artery bleeding happens and results in huge hematoma. A pterion is a thin bone in which middle meningeal artery ruptures and there is a hematoma happening. So please remember, this is due to middle meningeal artery bleed. On the other hand, this is due to SDH is due to bridging vein damage. Bridging vein damage. Okay, the bridging vein gets damaged. If the bridging vein gets damaged, it will be a compression directly happening on the brain. So it will have LOC from the time of injury. Okay, so SDH can be further divided into two types. The types of SDH are acute SDH and chronic SDH. Acute SDH usually follows trauma. The moment you get trauma, you get acute SDH in trauma. So acute SDH is seen in trauma. Immediately after trauma, there is a bridging vein damage and there is acute SDH. Chronic SDH is seen in old people taking what? Old people taking anticoagulants. Even trivial trauma, small trauma, just if they will hit on a small door, immediately they will get a chronic SDH. On anticoagulants, people on anticoagulants will develop this chronic SDH. So acute SDH needs craniectomy. We have to immediately open the cranium, craniectomy and evacuate the hematoma. Craniectomy and evacuation is needed for acute. Chronic SDH can be treated by just Burroll. Burroll is enough for chronic SDH. And easy to treat is EDH because the treatment of EDH is very easy. We can easily go for a Burroll. We put a Burroll and let out the hematoma. And the best prognosis also seen with EDH. Best prognosis also seen with EDH. The mortality is less than 5% mortality. But SDH has very bad prognosis. Acute SDH can have 40% mortality even with all type of treatments. Even with all type of treatment, the mortality in acute SDH is around 40%. So please remember, the types of hematomas are EDH, SDH, intracranial hemorrhage. Overall, the most common hemorrhage is intracranial hemorrhage and it is usually abdominal hemorrhage seen in hypertension patients. EDH is due to rupture of middle meningeal artery. That is a lucid interval. SDH is due to rupture of bridging veins. There is no lucid interval. Patient comes to hospital from the time of injury. Acute and chronic are the two types of SDH. Please don't forget this. Acute and chronic are the two types of SDH. Chronic is seen in old people with anticoagulants. Patient on anticoagulants. Patient who are on anticoagulants, old people will develop this chronic SDH. Okay, please don't forget these types of hemorrhages in the skull. Hemorrhages in the skull you should not forget. So please don't forget, for making Burroll, we have special instruments available. I will be showing you the instruments in image. Burroll is a treatment of choice for EDH as well as for chronic SDH. We can go with Burroll itself. That itself will be enough. And for acute SDH, we have to do decompression. We have to do decompressive craniectomy. We have to open the cranium and remove the clots. Decompressive craniectomy is advised for acute SDH patients. Okay, please don't forget these neurosurgeries which are commonly done in trauma patients. Okay, so these are the points I want you to know from head injury. So these are the IL points from head injury questions. Okay, so next let me go to the other types of injuries. Other types of injuries include diffuse axonal injury. What is this diffuse axonal injury in the brain? Severe accident. The skull is moving very fast and going and hitting somewhere. In this moving fast, that deceleration causes the axons to disturb and the patient goes for loss of consciousness from the time of injury. Very poor prognosis, no surgery available. There is no surgery can be done. We have to wait and watch. Patient will be going to coma, and as you have seen in movie Vasul Raja, there will be one fellow in coma for a long period and slowly he will be recovering. Like that, the patient will be in coma for a long period. And investigation of choice is an expected question, that is MRI. MRI is an investigation of choice for diffuse axonal injuries. Okay, so please don't forget, MRI is an answer for diffuse axonal injuries. And skull fracture. Skull fracture is another problem in the skull. It can be a depressed fracture. Depressed fracture will not worry. Many times they don't cause any symptom and you can even manage conservatively. Or displaced fracture. Just depressed means that would have gone inside, little inside, that's all. Displaced fracture or open fractures. Displaced or open fractures must be treated surgically. You can manage depressed fracture conservatively. Displaced and open fractures must be treated by surgery. And these cases need antibiotics also to prevent infection in the skull, inside the skull. So we have to give them antibiotics also. So these are the points I want you to know from AIS 1, which is known as head injury. AIS 1 known as head injury. The next injury is AIS 2 known as face injury. The face, this is AIS 2. The injury on this face like this. There is a hit on this face like this. That is known as AIS 2. In face injury, what is the most common injury? When there is a hit on the face, what is the most common bone fracture? It is nasal bone fracture. That is the most common injury in the face. Nasal bone fracture is the most common injury on the face. And there are many other injuries like this is the skull. Okay, this is skull. This is nasal bone orbit. So now if you see, this is. Now we are going to have injuries of the maxillofacial bones. Maxillary injuries. So maxillary injuries is given a classification known as Lee-Fort classification. You will be reading in ENT. How many types are there? In maxillofacial injuries, Lee-Fort, how many types are there? There are totally 3 types. Type number 1, you will have injury at the level of heart palate. This is 1. At the level of heart palate, there is a fracture. Heart palate level, there is a fracture. 2 will have an injury like a pyramid. So 2 is a pyramid-like injury. It will go like this and come like this. Pyramidal injury is 2. So this is an expected question. Lee-Fort, which injury is pyramid shaped? And Lee-Fort 4 is this. So 3 is this. So what is Lee-Fort 3? The 3 is going along the base of skull like this. In this, the cranium is disconnected from the face. Craniofacial dislocation. 3 is craniofacial dislocation happens. So please don't forget, maxillofacial injuries are three types. Type 1 is at the level of hard palate, type 2 is pyramidal, type 3 is craniofacial dislocation. So type 3 will have CS of leak, CS of rhinorrhea will be there in type 3. So what are other injuries? Apart from maxillary leaf injuries, we have injuries of the mandible. This is a mandible, okay? This is mandible. If this is a mandible, this is left side mandible, what is the most common site for you to get the injury in the mandible? So the most common site of injury is at the neck of condyle. This is a condyle. The neck of condyle is the most common site of injury. Most common is neck of condyle injury. And then angle of mandible injury. Then at the level of canine tooth, 1, 2, 3. The order of fracture of mandible is condyle, angle, at the level of canine tooth. So these are the order 1, 2. This can be asked as order-based question in names, sequence-based question in names. And last one is middle of the mandible. This is the middle, last point. So in mandible, 1, 2, 3, 4. 1 is neck of condyle, 2 is angle of mandible, 3 is canine level, and 4 is middle of the mandible. This order of injury of mandible. And next comes, what other area is there in your skull? So another area is this bone. What is this bone? Very important bone. What is this? Zygomatic bone. Okay, the zygomatic bone can get fractured. Zygomatic bone can get fractured. Another thing is the orbit can get fractured. So orbit has 4 walls. There are 4 walls in the orbit. What are the walls? The walls of orbit are, this is medial wall, this is lateral wall, this is roof, that is roof, and this is floor. This is floor. Now tell me, which wall will be commonly injured? Which wall will be commonly injured in this 4? So the order of injury is floor is the first important wall to be injured, followed by medial wall, and followed by lateral wall, and then last one is roof. This is the order of injury of orbit. Floor, medial wall, lateral wall, floor, medial wall, lateral wall, roof is the order of injury of orbit bones. And an important point I want you to know here is the orbit bone gets fractured, there will be restriction of movement of the eyeball due to trapping of the muscles. The most important muscle that is trapped in children is inferior rectus. In orbit fracture, inferior rectus gets trapped. In children, most commonly, inferior rectus trap happens. And all these facial bone fractures, investigation of choice is what? Treatment of choice is what? That's all. For AIS2, investigation of choice is CT scan is the investigation of choice. Treatment of choice is ORIF. What is ORIF? Orthopedicians will know this better. Open reduction internal fixation is known as ORIF. Investigation of choice is CT scan. Treatment of choice is ORIF. Open reduction internal fixation. Coming to AIS3, what is AIS3 injury? That is neck injury. In neck, you can get 2 types of injury. Putting a knife on the neck, penetrating injury. Okay, penetrating trauma. Most of them, when they try to kill someone, they will put a knife on the neck only. Another is hitting very hardly in the neck, blunt injury. So in your entire body, when you put a knife on the neck, that carries the highest mortality. Please remember, if you want to kill someone, you should kill him only with a knife on the neck. Don't put a knife on the abdomen, thorax, or back. They won't. Highest mortality is seen with neck injury because the major vessels will be cut. Highest mortality among all penetrating traumas in your body is penetrating injury to the neck. Okay, penetrating injury to the neck. And in the neck, you have the following zones. The following zones you have in the neck. The neck zones, you must know, have an idea. Have an idea about the neck zones. Zone 1 is from sternal notch to cricoid bone. So this is zone 1. Sternal notch to cricoid cartilage. Sternal notch to cricoid cartilage. This is zone 1. Cricoid cartilage to angle of mandible. This is zone 2. Angle of mandible is known as zone 2. This is zone 2. Zone 3 is from angle of mandible to base of skull. Angle of mandible to base of skull. So this is the least accessible zone. Least accessible zone. 2 is most accessible zone. Most accessible means we can operate. Which zone we can operate easily. Zone 1 is the third zone. So what are the zones available in the neck? Zone 1 is sternal notch to cricoid. Zone 2 is cricoid to angle of mandible. Zone 3 is angle of mandible to base of skull. So please don't forget these 3 zones. In these 3 zones, which is most surgically acceptable and which zone carries highest mortality also is this zone. The zone where the highest risk of damage is this zone. Okay? Highest risk of damage is in this zone. So please remember this point in penetrating injury. In blunt injury of neck, there will be cerebrovascular injury. In cerebrovascular injury happens in blunt injury. So that is known as, that is given a grading system known as cerebrovascular injury is given a grading system known as Denver's grading. That is given a grading system known as Denver's grading system. Not asked for PG exams. Just remember there is a grading system of cerebrovascular injury in the neck known as Denver's grading. So according to Denver's grading, it is given in your material. I have given the grading, not much important for PG. Again, it is not important for PG. The lumen is narrowed 25%. The lumen of the vessels is narrowed 25% because of hematoma there. 2. The narrowing is more than 25%. That is a blunt injury, that is a hematoma, and that is causing narrowing less than 25% is 1, more than 25% is 3, and 3 is pseudoaneurysm. That is a pseudoaneurysm formed in the vessel. 4 is occlusion of the vessel. The vessel is completely occluded. The vessel is completely occluded, and 5 is there is transection of the vessel. The vessel is transected. So what do you do now? In grade 5, there is no other option except immediately you have to intervene. So grade 5, surgical or endovascular option needed immediately. Or endovascular stent should be done immediately. So please remember, in the neck there are 2 injuries. Putting a knife is penetrating trauma. Hitting like this is a blunt trauma. In blunt trauma, the blood supply to the brain will be disturbed, and that is known as cerebrovascular injury. And the hematoma causes less than 25% narrowing is Denver's grade 1. More than 25% narrowing is Denver's grade 2. And 3 is pseudoaneurysm. 4 is occlusion. 5 is transection. And all these patients coming under blunt cerebrovascular injury will be started on anti-thrombotic drugs. Anti-thrombotic drugs like antiplatelets will be started for them. So the initial treatment will be anti-thrombotic or antiplatelet drugs will be started for these cases. So now in this chapter we have discussed 3 systems: AIS 1, 2, 3. Head injury, I have discussed head injury, I have discussed face injury, I have discussed neck injury. Let me show you the images. So just see the images. I have put all the 3 points on your workbook, so you can follow the workbook. This is the image showing you Monro-Kelly doctrine. Brain, CSF, blood is fixed component. If one component increases, for example, if the mass increases, it will compress the brain and other components. So this is skull is a fixed compartment. We should have a fixed ratio of the substances in the skull. And this is a picture from William Lau. You can see the herniations of the brain. So number 1 is cingulate gyrus herniation. Because of this hematoma, cingulate gyrus herniation. This is midline shift. This is uncus of temporal lobe herniation. This is brainstem herniation. This is cerebellum tonsil herniation. In this, the only PGM question is, in uncus herniation, what happens? There will be pupil abnormalities. In cerebellum tonsil herniation, there will be Cushing triad. Please don't forget Cushing triad, hypertension, bradycardia, and irregular respiration. Okay. So what are the things to be done? What are the drugs to be avoided in head injury? Can you tell me? Steroids don't give. Steroids should not be given. Lumbar puncture should not be done. And you should not give diazepam for sedation. These are the things that must be avoided in head injury. Okay. We will give sedatives, the barbiturates. Mannitol is ideal for ideal fluid to reduce intracranial pressure, and seizure prophylaxis is given with sodium valproate or phenytoin. Okay. And ICU values, what are the ICU values I told you? Intracranial pressure should be less than 20, cerebral perfusion should be more than 60, mean atrial pressure should be 80 to 90. Please don't forget, mean atrial pressure should be 80 to 90 in an ICU. So this is external ventricular drain. From the skull, you can see the CSF is being drained out, external ventricular drain done. This is a decompressive craniectomy, you can see the skull being removed out. And GCS, please don't forget what I told you, the best score is 15, worst score is 3, intubation must be done for score less than or equal to 8. So on this point, when there is a two different score in two different limbs, take the best score for two different limbs. Best score is taken for two different limbs. So VNT is for intubated patient, 0 point given for them, 0 points. This is a picture showing you Hutchinson's pupil. You can see the fixed dilated pupil known as Hutchinson pupil. In this image, you can see the fixed dilated pupil. And this is raccoon eyes or panda eyes. This is battle sign, bruising behind the ear known as battle sign. This is CSF otorrhea. And these are the various points I told you. Middle cranial fossa fracture, you get battle sign. Posterior cranial fossa fracture, you get Bernard syndrome. All these I have given in your material. So NICE guidelines to take CT scan, please don't forget. And this CT scan showing you the extradural hemorrhage biconvex shaped. Okay, biconvex shaped. And STH, you can see concavo convex shaped. Concavo convex shaped. And this is the instrument used for making burr hole. You can see the typical instrument, manual burr hole machine. This is a manual burr hole machine. And you can see one video I'm showing you here, in which STH is being removed. You can see the skull is getting opened. They are making burr hole. After making the burr hole, they are going to remove the cranium out. You can see the cranium is getting removed out. The cranium is lifted, and now they are opening the durameter. And I'm opening the durameter. There is a huge hematoma seen inside. The hematoma is also getting removed. And after removing the hematoma, they are clearly removing the hematoma and arresting all the minor bleeding also. And now they are reclosing the structures, and the surgery is getting completed. This is how they remove the acute STH. So now I have a few questions. Head injury patient was intubated. No I response. So no I response means E1. Intubated means VNT. And exhibits decerebrate response. What is the decerebrate means? Motor response is 2. So the answer is GCS score is E1, VNT, M2. Simple question. Which of the following herniation numbered here causes anisocoria? What causes anisocoria? Can you tell me? Or unequal pupils is seen with 3. This is nothing but what? Uncus of temporal lobe herniation. Uncus. All of the following are indications of NCCT brain except which of the following is not an indication of NCCT? Open skull fracture, yes. One episode of vomiting is wrong. It should be more than 1. So this is wrong. Actually, there is another wrong answer. There will be retrograde amnesia and GCS less than 15. So the wrong answers here are A and B will not be indication for doing a NCCT. Sorry, A and C are indication for doing, B and D are not indication for doing NCCT brain. What is the best modality for the treatment of this condition shown below? This is making a burr hole. Making a burr hole. Goals in treatment to prevent secondary brain damage, neurointensive care unit values. Intracranial pressure should be less than 20. Cerebral perfusion should be more than 70. Mean atrial pressure should be 90. What should be the PCO2? It should be 35 to 40 millimeters mercury. It should not decrease below. That is wrong. Okay, these are direct questions. So these are case injury we discussed. These are the leaf foot at the level of heart palate, pyramid level, and craniofacial dislocation. Okay, faciomaxillary injuries. And this is neck of condyle, which is the most common site of fracture of mandible. And in orbit, this is the most common site, that is floor followed by medial wall. Floor followed by medial wall is the order. And coming to neck injury, these are the 3 zones. Zone 1, Zone 2, Zone 3. The most surgically accessible zone is coming under Zone 2, between cricoid cartilage and the angle of mandible. Please don't forget Denver's grading. It's an injury to the neck by blunt method. Okay? It is injury by blunt method. So these are the points I want you to know from head injury, face injury, neck injury. So now we have completed AIS 1, 2, 3. Hope you understood this topic well. We'll go next to AIS 4.